Got it. The Cannabis Center of Excellence was established in 2018, and we are a virtual Cannabis Center of Excellence based out of East Boston that brings together citizens, patients, academics, healthcare providers, and researchers to really drive the industry forward. Peter is, so I'm the president of the Cannabis Center of Excellence, and Peter is one of our scientific advisors. So over the last, since 2018, I've been fortunate to be the principal investigator of now 8 different research studies, and one tonight that Peter and I were co-investigators on that we'll talk more about. But I'm excited that we now will have new resource. So if folks are interested in understanding any of the past research studies that I've been the principal investigator of and Peter and I have worked on together, you can now go find a great resource on the Cannabis Center of Excellence website. Thanks to Keefe Studio and Gibby's Garden for the support to make that happen and to power it. So very excited that basically since starting my work as a researcher in 2018 in cannabis, all the studies that I've worked on have come up with a very similar theme of consumers, patients, or veterans reporting using cannabis as an alternative to other substances. Based on these, 8 different research studies and the results of those studies, decided to launch a iCount Cannabis as an Alternative research study last year. And that's the results that we'll be talking about today. And Peter and I were co-investigators on that. So for our webinar outline today, we're going to talk about a little bit about the background of the opioid crisis, cannabis use for harm reduction. We'll also dive into the data of the Cannabis as an Alternative study, and then we'll turn into an interactive discussion where we'd love to hear from you all in the chat, any questions or any reactions that you all might have to what we talk about tonight. So as we're going along, feel free to drop comments and questions in the chat. We'll be responding to those in the Q&A portion. And again, this webinar is being recorded and will be posted on the Cannabis Center of Excellence website for others to view later. And we will post a few polls in the chat, and we'd love to hear some of your opinions. So I'll first give a shout out to our webinar series partners. Big thank you to Green Lion Partners, Caroline's Cannabis, and Holistic Health Group for supporting this webinar series. And a big thank you to Talking Joints Memo, who's our media partner and great outlet for any kind of cannabis news in Massachusetts. And just to stop and acknowledge the co-investigators of the iCount Cannabis as an Alternative research study. One, Dr. Grinspoon, thank you for being a co-investigator. We are also joined by DJ Ritter and Alyssa, who are also online right now in this webinar. Vanessa Jones and Eva Rachel Tine, who is a leading co-chair of several working groups around substance use and recovery in Massachusetts. So diving a little bit into the background about why we felt like this is an important webinar and research study to conduct. There has been mounting, the opioid epidemic is growing in Massachusetts and nationally. And overdose death rates are increasing year by year. COVID did not help the situation. And we're also seeing that there are stark racial and ethnic differences among overdose deaths and rates. We're seeing a large increase in fentanyl present in many of the overdoses in Massachusetts, and 93% of the overdoses reported in 2022. In 2022, we're also seeing concerning new drugs such as xylazine and street drugs that are out there and continuing to cause overdoses. And we saw that in 5% in 2022 in Massachusetts. Males comprise most of the overdose deaths in Massachusetts, and the younger population between 25 and 44 years are really bearing the burden of overdose deaths. But here in Massachusetts, we are fortunate. The Healy Driscoll, Governor Healy took the lead in suing the big pharmaceutical giants and the Sacklers and causing the opioid epidemic. And as a result, there's millions and millions of dollars of opioid resettlement funding that's available across the United States and within Massachusetts to really address the harms that were caused by the opioid epidemic. When we really look at oops.
Am I allowed to vote?
Yeah, sure. Got a little distracted by the voting, but we hope you all vote. Yeah, so when we look at looking at the existing evidence in cannabis as a harm reduction alternative, more and more papers and more research studies and more opinions are coming out about the role that cannabis can play in a variety of capacities. And I look forward to hearing more from Peter after this presentation. But for now, there are clinical frameworks that are coming out. States are adopting this. Canada has adopted using medical cannabis and a role in opioid cessation and reduction. In 2019, one of the studies that I was the lead investigator on that was recently published in the Journal of Clinical Therapeutics was a cross-sectional self-reported survey of veterans, a national sample of veterans, but also a large sample of Massachusetts-based veterans. We asked them, veterans, how they were consuming cannabis, for what health conditions were they facing, and were they using cannabis to reduce any type of prescription medication. And in fact, over half of our sample reported using cannabis to reduce any type of prescription medication. And then 46% reported using less alcohol, 45% less medications, 24% less tobacco as a result of the use of cannabis. So some of the insights are thinking is cannabis is non-lethal, and this sample of veterans report using more harmful substances, but are using cannabis to reduce their use. Further into this study, we looked at the logistic regression, or the odds of particular factors among the veteran population that would be more likely to desire to reduce their medication use with the use of cannabis, or be actively reducing their use of cannabis. And what we found was veterans who were Black, female, served in active combat, and those living with chronic pain were 2 or more times likely to report a desire to reduce the number of prescription medications that they were taking by using cannabis. And women were 3 times, and people who used cannabis daily were 2.3 times more likely to report active use of cannabis to reduce some type of prescription medication. Now, all of that to be said, all of those research studies that have been published and conducted led us to today, and the iCount for iCount as an alternative study that was launched last year. So the objectives of this study was to actually really understand how cannabis consumers and patients choose to use cannabis to reduce the unwanted use of other substances, including prescription drugs, alcohol, tobacco, and we also included recreational street drugs in this survey. It was a cross-sectional national population-based survey of cannabis consumers and patients that have either used medical cannabis to reduce a substance in the past, they're currently using it, or were not and had the desire to learn more about it. The survey data was collected using convenient sampling methods, and the data was collected from August to November of last year, 2024. We had a total of 586 respondents to our survey, and a high proportion of 41% of those in our survey reported having been homeless in the past, or 28% currently homeless. We had a 28% of our respondents were military, and 28% self-identified as disabled. And you can see the racial breakdown and the age breakdown here, but with the majority of our participants being between the ages of 20 and 30, reporting as white, and over 53% reported that they have been faced or diagnosed with an opioid use disorder. When asked to describe their relationship to cannabis, survey respondents reported that they were current recreational consumer, followed by current and medical, reporting that they both consume medically and recreationally, and then about 19% reporting that they were just a medical cannabis consumer alone. When asked under what circumstances do you currently use cannabis, 30% of our sample reported medically indicated, recommended by a licensed clinical provider. So that meaning that they would have a medical cannabis card. 20% reported, again, just recreational consumer, and again, below, ongoing with recreational and medical. So we asked survey respondents also what types of health conditions that they find cannabis most helpful in treating. 76% of the participants reported they have used cannabis as an alternate therapy for health conditions or symptoms currently or in the past, and chronic pain followed by depression, anxiety, PTSD, nausea, vomiting, migraines, insomnia, ADHD are all conditions that our survey participants reported cannabis helpful for. And among our sample, 52% of the participants reported that they currently take medications for their health conditions and symptoms. And when asked if they were using cannabis to reduce their prescription medication, which types of medications, those were reported over-the-counter medications, followed by antidepressants, mood stabilizers, muscle relaxers, anti-migraines, beta blockers, sedatives, statins, benzos, and stimulants. When drilling down specifically in cannabis as an alternative therapy for opioids, again, 53% of the participants have been formally diagnosed with opioid use disorder currently or in the past. And of those, 69% have used cannabis to self-treat opioid use disorder, or have used cannabis to reduce the use of opioids. And 12% of our sample reported wanting to learn more about it. And you can see on the right the different opioids and substances that the participants in our study reported using cannabis to reduce the use of. Everything from fentanyl, codeine, morphine, Vicodin, heroin, hydrocodone, Percocet, oxycodone, methadone, and xylazine. Again, the sort of newer street drug that's coming on the market in Massachusetts and maybe in other locations. That's concerning. In terms of the use of cannabis as an alternative for other substances, 62% of participants have used cannabis to reduce the use of tobacco in our sample. 58% use cannabis to reduce alcohol. And to the far right, you can see the other substances, including cocaine, crack cocaine, DMT, LSD, kratom, MDMA.
Caffeine's number one.
Number one. I knew that would get you. It is number one. So the key takeaways from this study and the survey that we implemented last year, and just thinking through, the opioid crisis is growing, and there really is a need for innovative solutions that are addressed to tailor the individual needs, desires, and medical history of patients. And medical cannabis has been shown in clinical and public health settings to play a harm reduction role. It's not an all panacea, and we will talk more about that. And I look forward to hearing from Peter here in just a second. But there is evidence and supporting and emerging evidence of at least consideration of this and integration in certain aspects of the journey of opioid recovery. And then with study participants in our samples and in the previous research studies that I've conducted, report consistently reducing the use of alcohol, tobacco, opioids, recreational drugs, and prescription drugs that are unwanted, and couple that with the reported improved quality of life. So with the opioid epidemic accelerating, I think exploring the integration of legal cannabis into our clinical and public health programs here, and with the new opportunity of addressing the opioid epidemic with additional funding, I feel like there might be a really possible opportunity here. So one thing is, we have seen, I've just presented all of these sort of like results saying that people are choosing to, prefer cannabis. But I think there are a lot of challenges and still a lot of room and work to go here. There's models in states such as Illinois that has implemented an opioid alternative pilot program where you can bring in your opioid prescription and get cannabis instead. That is one option of different states trying to work on this. And more recently, and this is what I'm interested to discuss about, one recent study came out looking at, and it was really a case study report documenting a scheme of where dispensaries were able to donate cannabis for case patients to see if it could help them in their reduction of their opioid use and recovery. So there's new ideas popping up around the states. There's all these sort of new things happening. And I'm curious, and I'm going to turn it over now to Peter. And I'm curious to hear about, some of your thoughts from the reactions from the evidence that's out there, what we just presented, and from your clinical experience of what you've seen.
Well, people are definitely substituting. And, this is all about harm reduction. It's not about like no harms. Because cannabis does have harms. We're not sure that it's safe for pregnancy or breastfeeding. Of course, that's true with a lot of other medications. You can trigger or worsen people with psychosis and, family history of psychosis, and teenagers can get really knocked off track, and people can get addicted to cannabis. I think the rates of cannabis addiction have been a little bit exaggerated, but people can get addicted to it. So not without any harms. But it's all about harm reduction, because clearly by every metric, cannabis is safer than tobacco. It's safer than alcohol. It's obviously safer than opiates. So the question is not, is cannabis perfectly safe, which is sort of what some of the prohibitionists try to hold up as a standard, but like, is cannabis legitimately a safer alternative to some of these other medications? And in the studies that you've done, all of them, the studies that I've participated in with you, we have shown a decrease in other uses. Other substances when using cannabis. And, these other substances are not trivial. Like benzodiazepines can be really, Valium, Klonopin, lorazepam, Xanax can be really, really addictive. They can affect your memory. They can cause dementia. And many studies show that people use fewer benzodiazepines because cannabis is quite helpful for them to alleviate anxiety. Now, cannabis doesn't work for everybody for anxiety. For some people, it makes their anxiety worse. But generally speaking, for a lot of the people I treat, cannabis does help with anxiety, and you could lessen their use of benzodiazepines. Same with sleeping medications. I mean, again, cannabis is not completely harmless, and it doesn't work for everybody. Some people are wired when they use it and like clean up their kitchen and then like do an art project and stay up all night. So it's not like everybody gets sleepy. But generally speaking, I have a lot of patients, and there's a lot of data too, not just my patients, but studies. Especially this new real world data that people are really interested in, where you're looking at patient registries and patient outcomes, where people are substituting. I mean, when you're treating someone for sleep, what are your alternatives? There's like a tricyclic antidepressant, which can cause an arrhythmia and tends to make people really groggy. There's like Ambien, which is addictive, and which people have these dissociative events with, and they, wake up the next morning and like, their car keys are in a different place. Something like 10% of car accidents have Ambien involved in them, or they eat their way through the entire refrigerator and they're like, wake up and look at all the wrappers on the table. They're like, who ate all this junk food and left the wrappers? And it was actually, you take the Ambien, you could do these things and not remember them. So a lot of the sleeping medications are not very safe either. So that's why everybody's excited. Not everybody, a lot of people are very much not excited about it. The addiction people, for example, but that's a slightly different conversation. But many people are very excited about cannabis as an alternative. And then you look at like treating pain, right? Someone comes into my office, their back hurts, their hip hurts, their knees hurt, all the things, the chronic pain. 25 million people, 25 million Americans are suffering from chronic pain because as we get older, a little portlier, our knees or backs or hips start to hurt. And like, what are our options for chronic pain? There, Tylenol, which doesn't do anything except maybe destroy your liver. Opiates, which, the overdose deaths went up a little bit from 107,000 in the year before last to last year's 108,000. I mean, it's not getting any better. And opiates, not only is it the question of addiction and overdose, they make you really constipated, which is a huge problem in the elderly. I mean, people end up in the emergency room when they're constipated. They make you dizzy. You could have falls. You could have memory loss. So, if you're looking at cannabis compared to, and then there's non-steroidals, your Advil, your ibuprofen, your Motrin, your diclofenac. Now, 10,000 people think that these are safe because many of them are over the counter, but in fact, 10,000 people a year die from heart attacks just from non-steroidals. And then if you factor in all the bleeding that they cause, all the ulcers, the gastritis, the bleeding ulcers. And then finally, if you factor in the kidney damage, I mean, so many patients of mine in their 50s, 60s, and 70s, their kidneys are slowly dying, which is a really, really big deal because they've taken ibuprofen after ibuprofen. And we could have avoided so many of these problems if we had, like, 20 years ago, used a little bit of medical cannabis, a little bit of CBD, instead of bombarding them with nonsteroidal. So it's really not just the opiates, but it's many of these medications, the sleeping pills, the anxiety pills, and all the pills for pain. And when you look at all of these studies, the one thing that always goes up is health-related quality of life. People, when they start medical cannabis, their health-related quality of life goes up. And that's a really, really big deal because that's what it comes down to in the end. These people are sick, they're suffering, they're miserable. And if you can improve their health-related quality of life, that's a really huge deal. So there are a lot of reasons why people are interested in cannabis as a substitution.
Yeah, and I mean, it is one is the quality of life is something that we've seen over and over. People reporting return to work, being able to by using cannabis to reduce unwanted medications. One of the major barriers that I've seen too is the lack of medical education around this topic. And I wonder, there's, from what I understand, there's only 20% of medical schools that offer
13%.
13%.
Well, it's not only lack of medical education, there's like anti-education. I mean, the stuff that I was taught in medical school was such nonsense. Yeah. Like they had to give lip service to, helping people with nausea with chemotherapy because, they couldn't ignore it completely. But then it was like, mostly cannabis was spoken about like in the context of like psychosis and schizophrenia and brain damage and low sperm count and all these scary things, most of which aren't even true. And, medical students and residents are desperate. They're hungry for information about medical cannabis because all of their patients are asking them about it. 94% of Americans agree that people should be allowed legal access to medical marijuana. About 70% agree that recreational cannabis should be legal, but almost all Americans believe, Republicans, Democrats, independents, veterans, everybody believes that medical marijuana should be legal. So, patients are asking their doctors about this, and the doctors just don't know what to say. They used to be able to get away with, that's an illegal drug that's bad for you, and then shift the conversation. And the problem is that people really do want to get their information from doctors and nurses. Something like 60% of them want to get their information from their doctors, and like 2 or 3% of them actually get their information from their doctors because the doctors don't know very much about it. We're trying to change that. I mean, I work a lot about trying to educate doctors, but then they end up getting their information from like bud tenders, and like nothing against bud tenders, but they're not medically trained. They shouldn't really be advising about how to take care of these really complicated medical issues. And then the doctors are like, how could the bud tender give medical advice? And it's like, they wouldn't have to if you knew enough about this to have a decent, just a reasonable, helpful conversation with your patients. And the final thing I'll say, in my experience working with tons of doctors and patients as well, because you could hear from the patients what their other doctors think about cannabis, is that a doctor's particular vantage point really determines how in favor or against cannabis they are. Like, for example, oncologists, like 90% of them are in favor of medical marijuana. And a lot of them are quite knowledgeable about it because they see it helping their patients with chemotherapy or pain from cancer or nausea or weight loss. And it's really transformative. And on the other end of the spectrum are the pediatric or adolescent psychiatrists who see, or the addiction psychiatrists who see the relatively rare but very tragic cases of, the kid smoking tons of cannabis and then developing a psychotic episode that eventually turns into schizophrenia. Whether the cannabis causes a schizophrenia or whether it's the other way around, people who are like pre-schizophrenic or self-medicating with cannabis, that's a whole another discussion, but they tend to overgeneralize and be really, really against cannabis. I mean, overall, about 2/3 of doctors think marijuana is a legitimate medicine. Yeah. So we're making progress, but we have a long way to go, particularly in the nuts and bolts, the practical, like, this is how I can help you. You're my patient. Why don't you try a tincture under your tongue, 4-to-1 CBD to THC, start with a drop, do a couple drops the next night. Just a very simple nuts and bolts. Right. Doctors don't know anything about that.
And that's really sad because it used to be in our pharmacopoeia.
It did.
Right.
In like 1855 to 1944, it was in the pharmacopoeia, then it was stripped away. I wouldn't be surprised if they put it back in, but.
Interesting. And so why wouldn't you be surprised if they would put it back in?
Well, they're going to have to at some point. It is a medicine that, like, again, 94% of Americans believe in. Now, just because 94% of Americans believe in it doesn't make it a medicine, right? If 94% of Americans believed in ivermectin for COVID, that wouldn't be a medicine, that wouldn't be active. But something like cannabis, it just alleviates symptoms. I mean, in 1915, William Osler, the guy who founded John Hopkins, he was the father of modern medicine. He said that cannabis indica was the best treatment there is for migraine. I mean, it used to be like mainstream medicine until this like crazy period from like 1937 until I guess 1996 when California legalized medical cannabis. It's just been so harmful with 20 million arrests for nonviolent cannabis possession for no reason whatsoever.
Yeah, the war on drugs has taken a toll, not only for the cannabis side, but also on the opioid epidemic.
Oh, absolutely.
And the rollout of the opioid epidemic really starting in the last, 30, 40 years, right?
Well, there's so many contradictions. Like there are these doctors that are like bad actors. They're like pill mill doctors, and they just like, you give me $100, I give you a prescription. Like that's not really what your medical license is for, like to deal drugs. But at the same time, whenever they shut down a pill mill doctor or close one of these really shady opiate clinics, the overdoses go up, because all the people with chronic pain or who are addicted to the opiates all of a sudden have to buy the opiates instead of through a prescription in a pharmacy on the street where it's vastly contaminated with fentanyl. So when you bust these people, if you don't give people a safe legal supply, you just increase the opiate overdoses. So the war on drugs has just made it much more difficult to treat on every aspect. It makes it harder for people to get help when they're struggling. It makes it harder to study interventions like cannabis. It just has been a disaster from beginning to end. But that's a little bit off the beaten track for what we're trying to talk about today.
Yeah, no, I'm just popping in the chat and just seeing, thanks everybody for pumping in. We got Aaron who says, hi, Dr. Grinspoon. Last time I saw you was at the Cannabis Science Conference in Rhode Island. You presented your keynote talk while still healing from a broken leg. Was cannabis part of your healing regimen?
Off the record or on the record? No, cannabis, you have to be a little bit careful because like medical boards still send doctors to rehab for cannabis use, even though doctors are allowed to drink, use opiates, use benzos, take muscle relaxants, use Benadryl, take antidepressants. But yeah, I've been pretty open about my cannabis use. I mean, it helped me a lot with the pain, and it enabled me to use many fewer opiates. I personally, in 2005, got in a lot of trouble for an opiate addiction I had, which is a whole nother story. But I'm now 19 years in recovery from opiate addiction, which is pretty cool. And cannabis really helped me. It helped me with the withdrawal symptoms, and it helped me with some of the insomnia and some of the anxiety when I was struggling with opiates. And when I had this gruesome fracture in my leg in August of last summer, it really helped me use fewer opiates and helped me a lot with the pain. So I've used it. It's really helped me. It also helped me in medical school when we had these 36-hour shifts. I mean, you literally go to work at 7 in the morning and you come back at like 7, you leave at 7 at night, but like the next day. And I just have these like splitting migraines, like migraines so far beyond like normal migraines. And like, I could take Vicodin or whatever, Naperson, but the only thing that really helped, if I take like one puff, not even a lot, it would make the migraines go away. So I think it really helped me get through medical school, and I did really well in medical school. It didn't really, I think it helped my studies because I could get over my migraines, go to sleep, and then be ready the next day for the next 36-hour shift.
Yeah.
So yeah, I've used it, and I found it really helpful. I mean, I don't use it all the time, but and I never use it obviously before work or on call or anything like that. It's not even, it's miserable to have like responsibilities and to using cannabis, and you're just very stressed out. So I use it, occasionally for medical issues, and it's been really helpful, and it's just more helpful. I mean, again, it's a question of what is the least dangerous option, right? Like if I'm treating a patient with strep throat, I can give them penicillin, and there's a 1 in 1,000 chance they're going to have a fatal reaction or an anaphylactic reaction, maybe not fatal, to the penicillin. There are no like perfectly safe drugs. So with cannabis, again, it's not, is this perfectly safe? It's right. Like, is it safer than any of the alternatives? Or is it more effective? And I think for opiate withdrawal, fortunately, I've been through it many times because I was addicted for about 10 years. And, the opiate withdrawal symptoms are awful. You're like nausea, diarrhea, stomach cramping, you're shaky, you're restless, you can't sleep, you're depressed, you're anxious, you're sweaty, you're fidgety. And, the only medications they have like clonidine, which like slows your heart rate down a little bit. It helps a little bit. But cannabis is really, really helpful. I know this from thousands of patients and also from my own personal experience for opiate withdrawal. And I'm just really surprised that the addiction people are so against cannabis that they're not a little bit curious about why every single one of their patients said it really helped me with my opiate withdrawal. They sort of view them on the same level, whereas again, it's sort of harm reduction. And again, no one's going to say that cannabis is perfectly harmless. Well, there are a lot of people who say that. Nobody sort of in mainstream medicine is going to say that cannabis is perfectly harmless, but it's in many cases less harmful than whatever else we'd be using.
Yeah, exactly. And I think that's the point, is less harmful, right? And again, there's not any, of course, there are risks to anything. And there are side effects to anything. And one of the things I think is that has been a challenge for at least, the cannabis and proving out the science has been the fact that it's been federally illegal. And there has been some studies that have come out that showed the amount of funding that is dedicated towards showing the harms of cannabis versus the amount of funding that was shown for the medical benefits. There was nothing. There was nothing.
To get money to study cannabis, you had to show a drop in sperm count, a drop in IQ, or a drop in motivation. Something had to drop, or you wouldn't get fun. I talk about that a lot in my book, actually, about how people got around that to try to do studies. But more recently it's more balanced, and we're seeing more in other countries, like in Israel and in Europe and in Canada, more than here. But we're slowly starting to see more studies about the benefits as well as the harms. But we spent billions of dollars trying to prove harms of cannabis. And my father was a pretty legendary cannabis specialist, Dr. Lester Grinspoon. He actually said, paradoxically, we spent so many billion dollars trying to show harms, and we've dug up so little in the big picture, pregnancy, breastfeeding, psychosis, teenagers, and some addiction. I mean, those are big deals, but compared to like non-steroidals or opiates, we've discovered so little with all those billions of dollars that paradoxically, the US government has proven the relative non-toxicity of cannabis by trying so hard to prove its dangerousness and not finding that much.
Yeah, that's incredible. And, a lot of the research has been, sorry, we're having a little camera difficulties here. So I appreciate your patience with us. So, I mean, it's just been a real challenge to not have the funding to be able to really look at it, objectively, and really been focused more on the harms. We've got another question here in the chat. From Naomi. Will future studies be done to identify what chemovars are being utilized by test subjects? It's my understanding that the terpene beta-caryophyllene is the main chemical constituent, for lack of a better term, that is doing the heavy lifting in the instances in terms of opioid use disorder. That's really interesting. So beta-caryophyllene. So do you know of any studies that are going to be looking at chemovars specifically?
Well, there are a lot of studies. I think I screwed up the camera even worse than you did when I went to fix it. There are a lot of studies in chemovars. I mean, on the one hand, the chemovars are interesting because cannabis has 500 different components. And some, that's why some strains are different than others. Obviously, some make you, very energetic, and others make you good for pain, or sleep, make you really sleepy. So, obviously the different components play a big role. But at the same time, there's so much nonsense in advertising, in the dispensaries about the different strains or chemovars. The chemovar is a more accurate name because, it's not really a strain. But that there's a lot of BS in the dispensaries because, first of all, every dispensary has their own strains. Like, there's no longer like these consistent strains, except for these celebrity strains, which are like the same cannabis but cost 3 times as much because you're paying for the for the celebrity's name. We won't name anybody in particular, but it is ridiculous. But the cannabis isn't any better. But all the descriptions in dispensaries, if you read them, I noticed one day they're all like the same description. Gives you a cerebral burst of initial energy followed by a deep, calm, relaxing muscle release of tension. Like, they're all the exact same description. So I think the chemovars are going to be interesting, and I think that the different components like carboxylene are going to
beta-caryophyllene.
Beta-caryophyllene are going to be interesting. But at the same time, it's subtle, the differences, and people make these exaggerated marketing claims. And I just think the marketing claims have to be sort of more closely tethered to the actual research.
Yeah. And I think the importance of beta caryophyllene is actually very interesting because it has popped up in a number of different studies and conferences that I've been at, it being a very, very strong, medical cannabinoid. And, what's interesting is that, it's the entourage effect is extraordinarily important in cannabis and interactions of all the different cannabinoids. So I do know that, now there's more and more studies coming out or funding coming out with NIH funding. I know that a colleague of mine is working on, like you were saying, large registry trial type projects. We're looking at bigger data and trying to understand strain specific impacts on health outcomes. Then there are, and chemovar specific impacts. And there are studies that are ongoing that are looking at single compound and single.
Right, and a study just came up. Well, a study just came up that said they gave people THC and they studied their anxiety. Then they gave people limonene, which is one of the terpenes, and they the limonene didn't do anything. But then they gave the THC plus the limonene, and there was much less anxiety. So the THC and the limonene and the entourage effect were working together. The entourage effect just means that all the other 500 molecules, or many of them, not all of them, work well with the THC to kind of synergistically produce an effect. For example, the U.S. government legalized Marinol, which is just pure synthetic THC, in the late 1980s for HIV/AIDS patients, sort of how to take the wind out of the sails of the legalization movement by giving us something. And these patients said that pure THC was somewhat helpful, but it wasn't nearly as helpful as full cannabis. So, the other interesting thing is we fetishize high THC, so much in this country. And I really wish the THC levels were lower and that the other levels of cannabinoids like, CBD, which everybody's heard about, but or CBC or CBG were higher. Because my dad actually didn't call it the entourage effect. He called it the ensemble effect. He thought they all worked together. And the entourage effect really sort of implied that THC was like 99% of it. And all the others were like the entourage following the THC, but it really is an ensemble. And I think we could do a lot better if, during Prohibition, the smugglers all bred up the THC really high because that was the most economical to smuggle weed with like really high THC. But now that legalization is spreading, we could breed down the THC and breed up some of these other more medicinal cannabinoids, and the whole thing would be healthier, safer, and more medicinal.
And it's interesting that you bring that up because obviously there's THC doesn't always matter in cannabis, right? And the high THC content is not always what you're looking for.
Well, and people can overconsume.
Yeah.
If I've been called to so many of these parties where like baby boomers do the 3 bong hits they did in college when cannabis, 30, 40 years ago, when cannabis was like 3%, the same 3 bong hits. And now it's like 25%. And they freak out and like just have panic attacks. And it's easy to overconsume when it's this strong.
Yeah. And, I think there's a lot of, also interestingly, I saw recently because of legalization, changing out, like, again, breeding, not always the fully CBG or CBN or those other rich strains, and just focusing in. So having less of those on the market and then less of those in the world, we need seed banks, to be able to kind of contain some of these genetics. We have a fun fact here that beta caryophyllene is the last terpene to evaporate when making oils usually. So
right, and it works on the CBD2 receptor. So it would be good for like inflammatory conditions. Pain and inflammation are two sides of the same coin, but that particular molecule works on there's cannabinoid 1 receptors in the brain, and those are the ones that get you high, and the CB2 receptors are more in the immune system. So that wouldn't even get you high, which a lot of people don't like, but it would really could potentially help with a lot of inflammatory and immune conditions.
Yeah. Yep. Cool. We've got another question here. Could you discuss the impact on cannabis research funding if the federal government reschedules cannabis, let's say to Schedule 3?
Right. Well, first of all, cannabis should be descheduled, not rescheduled.
I agree with that.
It is safer than tobacco, which kills 500,000 people a year. It's safer than alcohol, which it just went up. I just wrote a blog about this in my Substack. Went up from 138,000 deaths a year to 172 deaths a year from alcohol alone. And cannabis kills about 0 people per century in direct deaths. So, I mean, it's just unbelievable. It hasn't, I mean, the whole criminalization of cannabis, again, where we go, the war on drugs is like this sort of ominous backdrop to this whole discussion, any discussion about cannabis, because, it just doesn't make any sense that a safer drug is Schedule 1, which is currently no medical utility and high abuse liability. And then all these other substances are freely over the counter. Now, if you make it Schedule 3, it's going to be very incoherent, in my opinion, because I could write Schedule 3 prescriptions as a primary care doctor for like Tylenol with codeine, or like anabolic steroids, stuff that's quite dangerous, but not as dangerous as Vicodin, or oxycodone. But like more than half of Americans live in a place where you could just walk down to the store and buy cannabis. Like 5 minutes from here, there's a recreational store. We could just go buy cannabis if we wanted it. So why would you go to your doctor and try to meet with your doctor who's busy and you have a million other things to talk to your doctor about, and try to get a Schedule 3 prescription when you can just buy it at a store? It's so incoherent. I think it'll help with research. It would help because symbolically, it would help more than anything else, because the U.S. government, which has been hounding people for cannabis use, arresting people, millions of people, throwing them in jail, and just pretending it doesn't have medical uses, is finally, if they do reschedule it to Schedule 3, is going to be like admitting that it is a medicine, which many of us have known all along. I mean, and it's also like ridiculous that it's in Schedule 1 right now, when you have Marinol, which is synthetic THC, you have nabiximols, which is a THC and CBD in many European countries, are medicines, and you have Apeledex, which is CBD, which is another FDA-approved medication. So if all these medications come from cannabis and they're FDA-approved, I don't get how cannabis is Schedule 1 with no medical utility and high abuse liability. It does have some abuse liability. It's more like low to moderate abuse liability. It's certainly not high abuse liability. It's crazy that cannabis is Schedule 1 and oxycodone is Schedule 2. It it's purely political. It has nothing to do with health and safety. But it would help research if we rescheduled it, but it would be much better if we just descheduled it, because rescheduling is sort of incoherent. And Schedule 3 is full of substances. Tylenol with codeine is like infinitely more dangerous than cannabis. I mean, nobody could argue that cannabis is more dangerous than Tylenol with codeine with like a straight face. So I just don't think Schedule 3 makes very much sense. I sense you don't disagree.
Yeah, no, I don't disagree. I don't disagree. I think, I mean, it would free up the ability for the federal government to invest in, cannabis research funding. And so, I mean, that I think it would free that up. It would allow, through the NIH and through other channels, whereas traditionally the funding's been going through NIDA.
Right, and it's less onerous to research a Schedule 3 substance than a Schedule 1 substance. Like,
yeah,
the oversight is so expensive, and so we have to have like special safes and special this and special that when it's a Schedule 1 substance. So I think it would get easier, but it's certainly not going to solve all the problems.
Yeah. All right, we've got another question in the chat. I'm curious whether you have any dosing details on how patients you have treated for opioid use disorder, which cannabinoids and at which levels?
Well, it depends what you're treating them for. I mean, use cannabis to treat a lot of the underlying conditions that fuel the opiate addiction, like the untreated anxiety or depression, which they think is in like 70% of people with addictions, or the insomnia or the anxiety, or if you're treating chronic pain, many people with opiate addictions have chronic pain, or if you're treating the opiate withdrawal symptoms. So, there's many different, opiate addiction is really complicated. Believe me, I know, I've been through it. And there are many different things that you're treating. I tend to think that cannabis is really, really helpful for, number one, for the pain. If you start new patients on cannabis instead of opiates, you're going to have fewer people addicted to opiates, because opiates are really addictive. Ironically, more people addicted to cannabis, but that's a less serious addiction. Number two, people who are on huge doses of opiates, you can voluntarily, only if they're interested, you can't take away anybody's opiates. So you have suicides, people are miserable and they buy their opiates in the streets. You don't want to like take away anybody's opiates, but you could offer to transition them off of opiates onto cannabis. And that's where their health-related quality of life always goes up if they're game to make the transition. Number three, if you co-use opiates in cannabis, you could lower the opiate dose because they work on very similar receptors by about 80%. And that can really help because a lot of the overdoses, a lot of the mischief you get into with opiates is dose related. So if you lower the doses of opiates by 80%, you could really avoid a lot of the problems. Number four, as I mentioned before, the cannabis is really, really good for opiate withdrawal symptoms. And there's no data that people do worse than Suboxone programs if they use cannabis, or very little data that, and there's some data contradicts that say people do better. And it's just so puritanical, punitive, and ridiculous that they test people at these Suboxone clinics or at these pain clinics, for that matter, for cannabis, and then kick them out if they test positive for cannabis. So that is unethical and needs to end. Now, the most complicated thing is like, we have buprenorphine, which is also called Suboxone, and we have methadone. And for people who are addicted to opiates, those have been shown to result, the use of them has been shown to result in a 50 to 80% reduction in overdoses and deaths. And with cannabis, I know thousands of people that have used cannabis to get off their opiates, but we don't have the same level of data. So if I'm in my primary care office and someone's addicted to opiates, I usually offer them buprenorphine, Suboxone, and I use cannabis as an adjunct for all the other things: the anxiety, the pain, the trauma, the mood, the restlessness, for all the nausea, all the opiate withdrawal symptoms. So I think that we use Suboxone as opiate replacement until we get more data from, like, for example, as you mentioned, that state where you could bring in your opiate prescription and get cannabis, Illinois. And if we get more data that cannabis does lower overdoses, but it's very hard to go against the data. So I just think it depends on the context. And again, it depends on like a neutral, dispassionate view of like, what's the least harmful option. And then you also have to go with the data. And, the data is complicated because, as we mentioned, very little money has been spent trying to show benefits of cannabis. Most of it's been focused on harms. Who knows? We might have had data that cannabis works just as well as Suboxone or methadone, but we don't right now. So I usually stick to those. And I don't recommend people go directly, just use cannabis to get off opiates, because I think that's a little bit dangerous given that we have so much more data for buprenorphine and methadone.
Thank you. All right, we have another question here. Are there any metrics on dosing of CBG for specific ailments?
We're just studying CBG, and there are a lot of animal data. There are very few human studies, because again, this has just opened up very recently, the study into this stuff, and there's tons of anecdotal evidence. I know tons of people that say muscle aches, take CBG, you feel better. But CBG doesn't even have very consistent dosing. Nobody's regulating any of these cannabinoids, which is one of the casualties of the war on drugs and one of the casualties of the fact that they're not legal federally. Nobody whatsoever is regulating them. Nobody's regulating the hemp-derived CBD products either. Your Delta 8s, your Delta 10s, those are very dangerous because there's literally no adult in the room regulating any of this stuff. So I just don't think people have worked out really. You can find a cannabis advocate that will give you all kinds of stuff, or a bud tender, but I just don't think it's really been worked out very well. Is that different from what you think?
Yeah, no, answered it really well.
Again, if they were regulated, it would be more safe. It would be safer, and we'd understand how to use the stuff, and it would be easier to study because we'd have standard doses.
Yep, exactly. So we've got only a few minutes left here. We've got a couple questions, and so can you talk about the doses of cannabis, THC, CBD, and other cannabinoids, and the timing of doses that people commonly use when trying to reduce opioid use? Could you kind of cover that a little bit?
Yeah, it's really person dependent. Everybody's different. Part of it's like if you have tolerance or not, right? If you've been smoking 3 joints a day for the last 5 years versus you haven't used it in 20 years. Part of it's your experience with cannabis. Someone says, I've used it in college and I had a good experience. I haven't used it for 10 years. They're going to do pretty well with it. An 80-year-old comes in, I heard from my friends that cannabis works, but, I have never tried it. Sorry, I just trampled Mary. I haven't, tried it ever. I've been against it, but now my back hurts. That person, you want to start low and go slow. And then it's very different. At low doses, it makes people less anxious. And at higher doses, it can make people much more anxious. But where a particular person is very variable. Again, depending on their experience, their tolerance, and just their neurochemistry, their biochemistry. So the best way to do it is just to start really low and go slow. Use the lowest effective dose like we do with any other medication. If they want to use it recreationally, that's a different issue, but which I'm not against. I think it should be legal. But if I'm treating someone medically, we just start really slow. We don't rush. If we use edibles, we take a dose and then we take another dose the next day. We don't make the classic rookie mistake of taking one and then nothing happens in 20 minutes because they take about an hour to kick in, and then you take 5 more and then freak out. I mean, I always tell patients, let's just be patient getting you to your dose. You might be a little disappointed because it takes a little bit longer, but the last thing you want to do is overshoot, have them have an anxiety attack, which can happen, is really miserable at high doses. Nobody dies, but you could have a miserable anxiety attack, and then they get discouraged from the whole project. So it requires a lot of just kind of personalized attention, a lot of follow-up, a lot of patience, and then you just you sneak up the THC, you add some CBD. If you want, you add some CBN. If you want to make them sleepy for insomnia, you add some CBG for muscle aches or for anti-inflammatory, and you just take your time and do it really slowly, patiently, and judiciously.
Awesome. Cool. We have one last question here. We have 2. One says, why not deschedule since all mammals benefit? Agree with that. Do you want to comment on that?
I agree with
mammals. All mammals have an endocannabinoid system.
I agree with descheduling. I haven't discussed this with all mammals. I do know that people think it's funny to give THC to their dogs, and the dogs can get really confused and out of it. And I think CBD is a better use for your pets, which ironically doesn't directly stimulate the cannabinoid receptors. But we need more research with the mammals. They certainly could benefit. I mean, it hurts them to use non-steroidals. You go to the veterinarian, they're like, oh, here's some, Indocin for your dog, or some, gabapentin. And who's to say that CBD is probably a lot safer than these things, but it needs to be studied.
Yeah. Agreed. All right. And the last one, can you comment on the acid cannabinoids?
Well, yeah, the acid cannabinoids are interesting. They didn't used to have a very long shelf life, so no one was really that interested in them. They just immediately degrade. And then recently, I think Bahulum was in charge of this. They've come up with ways to make them sort of more stick around longer. So, not just get degraded by heat and by light and by everything else that degrades these chemicals. So, for example, there's CBD, but the CBDA, the acidic version of CBD, is supposed to be like 100 times more potent anti-inflammatory than just CBD. And I've actually tried cream for a sore neck with CBDA, and it was amazing how effective it was. So I actually think there's a lot of potential in the acidic cannabinoids. THCA, people talk about its health benefits, its anti-inflammatory benefits. I think we need to do a little bit a lot more study on it, and the same with CBGA. So I think that it's really in its infancy because they haven't been stable, but now that they're stable, people are showing a lot more interest. And then furthermore, CBDA is really interesting. It's a very powerful anti-inflammatory.
Cool. Yeah, more exciting stuff to come. There's always something new and interesting in cannabis that's coming out.
The last few years, there were 4,000 studies a year.
Wow.
Which is hard to keep up with.
Wow, that is incredible. Well, I want to thank you all. I just want to give a quick plug. Thank you all for joining us tonight, and for registering for interest, for the questions. We really appreciate it. This is our first, again, out of 3 webinars. Our next webinar will be on April 23rd, where we'll be digging into Peter's book a little bit more. So we'll be doing some digging into Seeing Through the Smoke and really discussing more about clinical and patient education. So come on April 23rd. You can register or scan the QR code here and register for that webinar. And then our third of the series will be policy recommendations. So we've developed a policy at the Cannabis Center of Excellence with several colleagues, policy recommendations resulting from the results of this research study. And we've shared that with the administration here in Massachusetts and with local stakeholders. So we'll be covering that on May 23rd. So I just want to thank everybody for joining us tonight, and a big thank you to our sponsors and supporters, and thank you to Peter.
Thank you to Marion.
Yeah, and thank you to Caroline's Cannabis, Holistic Health Group, and Green Lion Partners for helping support this webinar series. So we'll thank everybody, and we'll see you hopefully at our next webinar.
Hey, bye-bye.